All right, so in order to understand occlusion, we kind of have to go through a brief overview of the anatomy of the masticatory system. And that includes the teeth, which are supported by the alveolar bone and the periodontal ligament. And these both help dissipate forces. Then we've got our skeletal components. We've got the maxilla that makes up the hard palate and supports the alveolar ridges that support the upper maxillary teeth. And then we have the mandible, which makes up the lower jaw. And this is U-shaped and it supports the lower mandibular teeth, the condyle, and the temporal bone of the TMJ. Then we have the TMJ. This is formed from the temporal bone of the cranium, specifically the glenoid fossa and the articular tubercle and the condyle of the mandible. And then in between that is a fibrocartilaginous disc that lies there. And the TMJ performs a gliding and hinge-like movement. Then we have the muscles of mastication. These include the temporalis, the masseter, the medial and lateral pterygoids. And these are responsible for the elevation, depression, protrusion, and retraction of the mandible or the lower jaw. Then we have the ligaments. And the ligaments are associated with TMJ, and they limit and restrict certain movements. Those ligaments include the temporomandibular ligament, the medial and lateral discal ligaments, the sphenomandibular ligament, and the stylomandibular ligament. So the development of occlusion really occurs with the eruption of the primary teeth somewhere around 6 months. And this varies with individuals. I know for myself, my daughter got her teeth at 4.5 months and had a full dentition by the time she reached a year old. And my son didn't have any teeth until he was around 8-9 months. So it really varies. But around 2 years old, all the primary teeth should be occluding or touching each other. And this is when your first primary molars should be fully erupted. And in some cases, like my daughter at 24 months or 2 years old, she even had her second primary molars. And over time, the jaw continues to grow and the teeth become spaced, which we know is called diastema. A mixed dentition occurs between the ages of 9 and 12 when you start getting the eruption of the premolar teeth. And when the premolar teeth erupt, they're much smaller than the primary molars, and this is the leeway space. So their small structure allows for the permanent molars to drift forward into class 1 occlusion, which we're going to go into. So centric occlusion is a term described to describe the spatial relationship between the maxillary and mandibular teeth when the teeth come in contact with each other. The spatial relationship optimizes the occlusal surface contact area. So this is when you're just closing your mouth naturally. The teeth are just resting together. So all the teeth are in contact except for the mandibular incisors and the maxillary third molars in centric occlusion. And sometimes it's lost due to tooth loss or restorative treatments that are not performed right away. And in other cases, it's lost through periodontal disease. It's really important to understand that occlusal trauma does not cause periodontal disease. What do we know that causes periodontal disease? Anybody? What causes periodontal disease?
Pathogenic bacteria?
That's right. That's right. So it's not the occlusal trauma. So with centric occlusion, you have centric relation. And this part gets a little bit tricky, but I'm going to break it down very simple for you to understand this. So centric relation is the relationship of the mandible to the maxilla when the condyles are in their most posterior and superior positions in the mandibular fossa. You can see over in the picture, the centric relation is pointing right at the condyle in that TMJ. So the centric relation is ideal when the mandible is in central occlusion or at rest. So the way to figure this out, to differentiate between these terms, because this is often tricky and gets mixed up. The way to remember it is that central occlusion refers to a teeth-to-teeth relation contact as pictured, and centric relation refers to a bone-to-bone relation, which would be the maxilla and the mandible, in which the lateral jaw movement can be made. So midlines play an important role in occlusion because it creates facial symmetry. The midline is seen as a line between your two upper front teeth and your two lower front teeth. This creates bilateral symmetry. When the midline is deviated or it's shifted to the right or left in malocclusion, the upper and lower teeth, they don't line up straight, and this creates asymmetry. So Edward Engel in the early 1900s, he was considered the father of modern orthodontics, and he pretty much was the first to classify malocclusion. He defined normal occlusion, and then he broke it down into 3 different classes: class 1, class 2, division 1 and division 2 of class 2, and class 3. Okay, so normal occlusion is the molar relationship, is the mesial buccal cusp of the maxillary first molar aligns with the buccal groove of the mandibular first molar. The canine relationship, you'll see the maxillary canine occluding with the distal half of the mandibular canine on the mesial half of the mandibular first premolar. So it's getting a little bit tricky here, and I'm going to give you a tip for this. The line of occlusion is when you look at the arch and all the teeth are fitting on a line of occlusion. So you've got this nice smooth curve on both arches. And the midline is very symmetrical between the upper and lower central incisors. So in this picture, you can see the nice U shape of the line of occlusion going over the maxillary arch. And then you can look at the mesial buccal cusp of the maxillary first molar, and it fits right into the groove of that mandibular first molar. So we're going to just stop here for a second. And does anybody have any questions so far? No questions? Great. Okay. So, if you guys have your Typodont, this would be a good time to locate it and get it out. And I brought mine. Let's see if I can show you this quickly. Sorry about that. Okay, if you can see me and my typodont. Did anybody bring a typodont with them? All right, perfect. All right, so you could use a pen, a pencil. I've got a washable marker. And what I want you to do is I want you to locate the mandibular groove on that first premolar and mark it. It's very prominent on my typodont. So I'm gonna go ahead and just color it black like that. You can see it like that. And then I'm just gonna outline the mesial buccal cusp of that maxillary first molar. And you can see how it fits in. That's class 1 occlusion. Does everybody understand that? So that maxillary mesiobuccal cusp fits right into that mandibular groove on that mandibular first molar. The easiest way to find occlusion, I find, is to just look at the molars. Sometimes I, even after 21 years of practice, have a hard time locating the canine, but I can go right to the molars. I can put both my fingers into the patient's mouth, ask them to bite down, turn right, turn left, and I look for that mesiobuccal cusp. Where is it fitting? Does it fit right in that groove? If it does, then you're at class 1. Okay, we're gonna go right back to our PowerPoint. Okay, so class 1 occlusion is also known as neutral occlusion. And with this molar relationship, it's exactly like normal occlusion. We've got that mesiobuccal cusp of the maxillary first molar, and it's occluding with the mesiobuccal groove of the mandibular first premolar. And the canine relationship, you've got the mesial line of the maxillary canine occluding with the distal line of the mandibular canine.
Val, the PowerPoint's not up.
Oh, it's not up? Sorry about that. Sorry about that. Okay, can we see this?
Looks good.
Okay, so I'm just gonna go back to that. So class 1 occlusion, same thing as normal occlusion. You've got the mesiobuccal cusp of the maxillary first permanent molar occluding with the mesiobuccal groove of the mandibular first permanent molar. Same thing. The canine relationship, you've got the mesial line of the maxillary canine occluding with the distal line of the mandibular canine. The distal line of the maxillary canine occludes with the mesial line of the mandibular first premolar. What's a little bit different in class 1 occlusion is the line of occlusion. So if you flip your typodont over and you're taking a look at the arch, sometimes this arch is not a perfect U shape, it's altered. And this could be due to individual tooth irregularities, due to crowding, spacing, or other localized tooth problems. Or there can be interarch problems. You can have an open bite, a deep bite, or a cross bite. But you can still be in class 1 because the molars are lining up and the canines are lining up. Usually with a class 1 occlusion, you'll see a mesiognathic profile. as you can see in this patient off to the side in this picture. So she's got a normal straight face profile with a flat facial appearance. You can see it closer here. We've got, looks like class 1. Here's the maxillary mesial buccal cusp fitting right into the mandibular groove on that lower mandibular molar. Here are the canines lining up, and the profile looks pretty normal. The only difference is, like I said, the line of the arch may be slightly altered due to some crowding. Okay, so class 2 distal occlusion, it gets a little tricky because it's broken up into division 1 and division 2. So the molar relationship in class 2 shows that the mesial buccal groove of that mandibular first molar is distally or posteriorly positioned to that mesial buccal cusp of the maxillary first molar. So the mesial buccal cusp of the maxillary first molar is resting in between the first mandibular molar and the second premolar. So it's almost like it's pushed forward. The canine relationship here in this class shows that the mesial line of the maxillary canine occludes anteriorly with the distal line of the mandibular canine. You'll notice that the distal surface of the mandibular canine is posterior to the mesial surface of the maxillary canine by at least the width of a premolar. So it's significant, the canine relationship. When we look at the line of occlusion in the arch, it's not specified, it's irregular. And again, this depends on facial pattern and overcrowded of teeth and maybe space needs. These patients have a profile that's termed retrognathic. This is a convex face profile, and it results from the mandible that is too small or a maxilla that is too large. And you can see it in this picture. So if you look at the mesial buccal cusp of the maxillary first molar, it's forward. It's pushing more mesial to that mandibular groove. Here, look at the way the canines are lining up. And then this creates the central incisors to slightly flare out. So basically everything's kind of pushed forward. You can see in the patient's profile, she's got like a widened upper lip, a small chin. You can see the way the molars are lining up in her jaw. So now we're going to go into division 1 and division 2 of class 2. So the only difference here is division 1, everything is going to be the same in class 2. You've got the same molar relationships. The difference is those anterior teeth are going to be protruding out over the lower anterior teeth. This is overjet. So protruding out is an overjet. In class 2, division 2, those central incisors, those anterior teeth, they're retroclined, meaning they're tipped back and in. So you're not getting the flare, they're going the opposite way. They're going tipped in. And when this happens, you get a deep overbite. This is a great comparison of division 1 and division 2. So in division 1, again, you've got the upper incisors are proclined. They're jetting out. In division 2, you've got those upper central incisors that are going lingually inclined. They're tipped back. They may even be overlapped by upper lateral incisors. In class 2, division 1, we have an excessive overjet, which you can see in the picture, this big flare of the front teeth, and you're going to get a deep overbite. In class 2, the only thing you're going to see here is a very deep overbite. When you're looking at the line of occlusion, you're going to have a more V-shaped than a U-shaped arch. It's going to be very narrow on that palate in the canine region, and it's going to be broad between the molars. And in division 2, it's just going to be overly broad. Appearance-wise, in division 1, you're going to have a short upper lip. There might even be a failure for the lips to close. And division 2, you're going to see a normal upper lip, and you'll see a good seal. The mandible in division 1 may be deficient, and the chin may be underdeveloped. But in division 2, it might seem more like a normal size. So class 3 is our mesial occlusion, which is our negative overjet. This is probably the easiest occlusion to identify. So the molar relationship in class 3 is that the mesial buccal cusp of the maxillary first molar is occluding distally or posteriorly to the mesial buccal groove of the mandible. So it's going backwards. And in the canine relationship, you'll see the distal surface of the mandibular canines are mesial to the mesial surface of the maxillary canines by at least the width of a premolars. And in often cases, if not all the cases, the mandibular incisors are in complete crossbite, which means they're overlapping those upper teeth instead of it being the opposite way. Your line of occlusion is going to also be irregular. We're not going to see a U-shaped. And this is, again, facial pattern due to overcrowded teeth and space needs. And the patient's profile is going to be prognathic, where you're having this concave face profile and a very prominent mandible that's kind of protruding out. This is classic of class 3 malocclusion. So I lined up all of these so we can go over them really quick, so you can just differentiate very quickly by just looking at the molars. This is the way that I can quickly identify the classification when I'm looking at my patients. So ideal is our top one. Again, we've got the mesial buccal cusp of the maxillary first molar right in the mandibular groove of that mandibular first molar. We go right down to class 1. It looks exactly the same. The only difference is you can see if you're moving anteriorly, you've got a little bit of crowding going on here, but those molars are lining up, and therefore we're going to call it class 1. In class 2, over to the right, you can see that that maxillary mesial buccal cusp has come forward to that mandibular groove on that first molar. And then in class 3, over to the left, we can hardly even see the mesial buccal cusp of the maxillary first molar because it's so distal or posterior to the mandibular groove on that first molar. And you can also see how the teeth are, the lower jaw is a lot bigger, and you can see the overlap. So overbite and overjet happens to be part of malocclusion. And this is when the upper teeth protrude over the lower teeth by a proportion of between 30 and 50%. And the most common cause of an overbite is the shape and or the size of the jaw or the teeth. And sometimes this is caused by genetics. Sometimes it's grinding, it's bruxism, it's TMJ dysfunction. And when you have this type of overbite and overjet, It can lead to complications like tooth decay, gum disease, severe worn tooth enamel. Patients can experience jaw pain or severe headaches like migraines. They can have discomfort or pain when they're eating. They might even have trouble fully opening or even closing their mouth. Sometimes we see sleep apnea, and there can be difficulty speaking or having speech issues. So the term overjet and overbite is commonly used to describe horizontal and vertical overlap of the teeth. The easiest way to remember these terms is that overjet is horizontal and overbite is vertical overlap. And so you're going to want to take your probe, and this is how you're going to want to measure it. So again, we've got a vertical overbite is where the top teeth are significantly overlapping the bottom teeth. This is moderate or deep. You can see in the picture, this is how you hold the probe. You're going to hold the probe vertically and take your measurement. When you're measuring a horizontal overbite, this is when the teeth are protruding out and over the bottom teeth. And you're going to hold your probe horizontally and take your measurement that way. Does anybody have any questions? Okay, I'm going to move on. So this is a great picture of overjet. This is this really protrusion of those central incisors. And then if you look over to the deep overbite, the bite is so deep you can't even see the lower anterior teeth. That's just a recipe for disaster. That's a lot of incisal wear. The load of forces on these teeth is big. And so you'll want to correct that. Okay, so an underbite, which we know is a class 3 malocclusion, also called prognathism. And this is when the lower teeth, again, are overlapping the upper teeth. And the severity can vary between a mild underbite, where the 2 rows of the teeth almost meet each other, or you've got a situation where the teeth don't meet at all because the gap between the arches is so wide. And this, again, is caused by genetics. It's caused by a misalignment of jaw at birth. And even certain ethnicities carry the underbite characteristics. And so with an underbite, we've got complications like eating difficulties, challenges with speaking, chronic jaw or joint TMJ pain, as well as head and earaches. We can see tooth decay from excessive wear of the tooth enamel. Often your patients that have an underbite are chronic mouth breathers. This can lead to halitosis and bacterial infections, and they can even have breathing difficulties with snoring and sleep apnea. Here is classic underbite. You can see in the left picture those lower anterior teeth just kind of covering over those central incisors. And if you look at his jaw, you can see his jaw is more pronounced, doesn't quite line up. His profile doesn't quite line up. The maxilla looks a little bit smaller, and it's really not. It's just that the jaw is protruding more forward. So an edge-to-edge bite is another common malocclusion term. And this is mostly caused by grinding and clenching forces. In an edge-to-edge bite, you see severe wear on the occlusal and incisal edge surfaces throughout the mouth. Your teeth are going to have a real flat appearance. In some cases, the wear will be so severe that you can see the dentin coming through, and I've even witnessed the pulp showing through. So it's very serious to have an edge-to-edge bite. It can be very uncomfortable. Like I said, the interior teeth often have flat, jagged, incisal edges. In the posterior teeth, they will have flat, shiny cusps or wear facets. And if anybody remembers what wear facets, it's like these perfect little circles on the molars. And that's just where the upper and lower teeth are constantly hitting each other. They're just wearing out the enamel there. You'll also see abfractions at the gum line. You can see some of them in the photo to the right. These are just like notches. It's just like chopping down a tree. You just keep cutting into the tree and you get these really deep notches. And you can see, you know, obvious recession. And most of these patients are going to be sensitive to hot and cold, and even sweet, especially in their molar area near the wear facets. So an open bite is another form of malocclusion. And this is when the maxillary anterior teeth and the mandibular anterior teeth do not touch at rest. And this is from a thumb sucking or a finger habit. You get this from pacifier use, a tongue thrust, TMJ problems, or even skeletal issues. Most of the time when you remove habits, or you correct habits, I should say, an open bite can resolve itself. So crossbite is very common when we're talking about malocclusion. And in a crossbite, you have the mandibular teeth just overlapping the maxillary teeth, when we know it should be the other way around. And you can see it in the front, in the anterior, and you can see it in the posterior. It can be bilateral or it can be unilateral. And crossbites are often, again, caused by genetics. Sometimes they're caused by a delay of the primary and permanent teeth, or habits like thumb sucking or mouth breathing. You can see in a lot of the pictures just where we've got those mandibular teeth overlapping the maxillary teeth. You can see the interior crossbite there. They're covering those central incisors. And in the posterior, we've got that mandibular first molar overlapping that maxillary first molar. So single tooth malalignment terminology, this is kind of important because you need to understand these terms in malocclusion when you're just specifically talking about teeth. So labial verted is a malposition of the tooth when it's labial to its normal position. And we know that labial means out towards the lip, or in some cases out towards the buccal. When you have a lingual verted tooth, this is a malposition of the tooth that's more lingual to its normal position. And when we say lingual, we mean more towards the tongue. When we have a torso-verted tooth, this is when the tooth is turned. You see a lot of torso-verted teeth in crowding. So why is occlusion and dental hygiene important? So as a dental hygienist, We are the patient advocates and we are the co-therapists to aesthetics and the functionality of the oral cavity. So it's really our job to observe these clinical findings. And the way we're going to do that is we're going to identify what classification the patient is, if it's class 1, 2, or 3. Then we're going to measure the overbite and the overjet with our probe. We're going to take notice if there's an underbite, if there's an open bite, or a cross bite, and we're going to document those findings. The next thing we're going to do is we're going to look at the line of occlusion on the arches. Are we looking at a nice U-shaped arch? Or are we looking at an arch that's omega shaped, which just means an arch that's very crowded? We're going to want to check our TMJ through our extra intraoral exam. You're going to want to be looking for any popping, clicking, when you're asking the patient to open the jaw, close the jaw, and shift side to side. So you're listening for those things. And then you want to check the muscles of mastication. And these are palpable. So you can do your extraoral exam and palpate all of these muscles near the joint, right above the maxillary teeth. And I like to perform my exam by inserting my pinky or my thumb in their buccal mucosa, and I have the patient bite down and I feel the muscles that way. And a lot of times I'll get, oh, that's really sore, or I can feel the tightness in the area. And that tells me that those muscles are being stressed, and they're probably being stressed from grinding and clenching. So after we observe these clinical findings, the next thing you're going to want to take a look at is the overall condition of the teeth. Is there wear on the teeth? What does it look like? Are we seeing flat, jagged edges in the anterior region? Are we seeing flat cusps posteriorly? I know from experience, I've seen many patients that look like their posterior cups were chopped off by a chainsaw, completely flat. This is also very noticeable on radiographs. So they don't have those nice points anymore. They're just completely flat. In some cases, you'll see the wear facets. They'll be really shiny on those posterior teeth. They might be sensitive when you run the Explorer over them. That's because the enamel is worn in those areas, and you now are looking at the dentin, which we know is sensitive. The erosive surfaces, it's the same thing. We're dealing with loss of enamel, and we're dealing with dentin that's highly sensitive. Abfractions is another indicator. Do we see the notching at the gum line? And remember, notching is different, or abfractions are different than our recession. So we know our recession is showing our root surface, and our abfractions are a complete notched out area under the crown, notched out into the root surface. So it's like a V shaped. Like I said, imagine you cutting down a tree with an axe and you just cut halfway through it. That's an abfraction. Now, the next thing you want to look for are any of the teeth mobile. If you've got so much force going into your occlusion, you're going to see mobility. I had a patient who had optimal oral hygiene, and all of her premolar teeth were class 3 mobility. And I will tell you that it was not from periodontal disease. Her bite was so off, and she was banging those teeth nonstop. She caused them to be extremely mobile. She ended up losing them and ended up with implants. Her bite was just completely off. This patient did not want to see a periodontist. This patient did not want to have her bite fixed with ortho. And she ultimately ended up losing those teeth and spending even more money replacing them with implants. So it's really important to try and gather all of the data so that you can get a big picture of what's happening with this patient. And then the last piece of the puzzle is take a radiograph. You'll see the bone loss on the radiographs. In a lot of x-rays, I know I can easily spot a stressed out periodontal ligament because it shows up very opaque on an x-ray. You can almost trace it. You can trace the ligament around the root of the tooth, around surrounding teeth. You'll see a crater effect in the bone. And again, this is excessive force from occlusion being off. So as a dental hygienist, what are some questions that we should be asking our patients when we're looking at occlusion and we're seeing some of these findings in their mouth? So these are just a couple of questions that you can ask your patients chairside. And you can ask them, have they ever noticed their teeth getting shorter, longer, or are they chipping easily? Do they ever have difficulty when they chew or they eat? Are they aware of any grinding or clenching of the teeth? Do you or have you ever had problems with your jaw or had an injury to your jaw or your face area? Are you aware or have had any pain or discomfort when you chew, talk, open too wide, or close? And do you ever hear any clicks, pops, grating, crackling? Same thing when you're opening or closing. And does your jaw ever stick or lock? So these are just a couple of questions that you can go through with your patients to try and get a bigger picture of what's happening with this patient and their occlusion. So next, you're going to want a treatment plan for these patients. And in doing that, you're going to want to grab all your diagnostic aids, and that's going to include your clinical findings and your radiographs. That can be a cephalometric x-ray, it can be a panoramic x-ray. Some offices have nice 3D scans where you can see everything, or even taking alginate impressions and getting models of their teeth and looking at their occlusion that way. Sometimes it's an interference with restorations that might be old or faulty, or even new restorations, and it's throwing off the bite. And in that case, your dentist can come in and adjust the bite and fix the interference. In other cases, you might want to review habits. If it's a child who has an open bite, you might want to talk to the parent about thumb sucking or finger habits or even pacifier use. You'll want to review the diet. Are they eating lots of things that are acidic, causing the wear, changing the enamel of their occlusion? And it's really important to go over oral hygiene instruction. In a lot of cases, these patients have crowding. And with crowding, we see inflammation. They're not in a perfect line. They can't optimally get in there with floss or toothbrushing and you see an overgrowth of gingival tissue, you see bleeding. So going over oral hygiene instruction with patients that have crowding is really important because you want to minimize the bacteria level when you see crowding. In other cases, you might just want to refer out for an ortho evaluation. An orthodontist can, recommend traditional braces. Invisalign is very popular. They might recommend an expander, like a palate expander, to kind of open up that narrow arch, kind of kick out those molars that might be lingual verted. And in some cases, they might recommend surgery, maybe removing teeth. A lot of times, an orthodontist removes the first premolars to kind of make room for the other teeth to get that nice U line of occlusion going on. In other cases, you might want to refer the patient for perio. Maybe they have significant bone loss and they might be a candidate for surgery. You'll want to manage symptoms. A night guard or a bite plane is the #1 thing that I go to first. Want to make sure that they're protecting the teeth. I'd rather have them grind or clench on plastic than do it on tooth enamel. And then I might prescribe sensitive toothpaste like Prevident, or I might recommend a fluoride varnish if they've got lots of areas of recession or abfractions, just to deal with the sensitivity issues that can come with malocclusion. And then lastly, you might want to discuss restorative options with the patients, building up anterior edges that have been lost, or even building up placing buccal composites on areas of abfractions to protect the tooth from eventually snapping over, which I've seen happen, or protect the tooth from even more wear. So does anybody have any questions?
I do.
Sure, go ahead.
Hi. In clinic, when we're doing the charting of the occlusion on the computer, it asks you for the skeletal classification. And it only says class 1, class 2, class 3. And I was wondering what does that mean? Is it the same as the dental, like the type of the dental occlusion, or?
This is on EagleSoft. I would have to see it, but I'm gonna guess that they're looking at your occlusion. Now, it's really, it's important to note that you can have multiple occlusions. You can be a class 1 on one side and you can be a class 2 on the other side. So it's, you're not just, a lot of times you're not just one.
It's just because it asks for like the actual occlusion, and then it asks, and then on a different question, a skeletal occlusion.
Yeah. So actually,
that's why we get confused. I never know what to answer.
If I can pop in real quick, if that's okay.
Yeah.
Okay. So do you remember the slides that Miss Valerie showed us that has the side profile of what each occlusion looks like? That is going to be what they're talking about, their skeletal class. So you can have someone who has a class 3 occlusion, but they don't have the bulldog look. They're able to camouflage it with their teeth. So you revert back to the slides that Miss Valerie showed us. We're looking at the side profile view, how it would look. So you can have somebody who is almost a fake out class 3, where their teeth are class 3, but they are showing, their side profile is showing up as more of a class 1. So that is more of their skeletal class as opposed to their molar class. So that could be somebody who, let's say, they had a tooth missing, and that caused some shifting in the back. So their molar relation is going to change, but their skeletal relation is the same. Does that kind of make sense at all?
Yes, it does. It does.
All right, awesome.
Thank you.
No problem.
Thank you, Ashley. Any other questions before we go on?
I have a question.
Sure.
So on EagleSoft 2, there's like an option where it says mesial step, distal step besides the occlusion. What is that? Because I've always like wondered, and I've always forgotten to ask what it is.
Mesial step and distal step. Ashley, are you there? Okay. I couldn't see you.
I'm here. Okay, so pretty much what that's talking about is it's talking about how the teeth themselves are occluding. So what you're looking at is in a class 2 occlusion, typically you're going to have more of a distal step, right? Because you have the one molar on top and this molar, and you have the first molar that's going to be more moved forward. So it's distally occluding on the mandibular one, okay? An edge-to-edge bite is going to be a one that you have the cusps right on top of each other. A mesial step one is where you're going to have a class 1 or even a class 3 occluding, where you're going to have the mesial surface of the mandibular molar out further. So typically you're going to look at the mandibular arch for this one, okay? So if the mandibular molar is facing more mesial than the maxillary molar, that's a mesial step. And if it's the opposite, where the mandibular molar is back further, so it's distal more, that's a distal step. So it's just the cusp relation of the tooth with the teeth that you're looking at themselves, if that makes sense.
It's kind of just breaking down the occlusion into a simpler term.
Like what part of the tooth is actually occluding with the other one.
Right. Is it mesial or is it distal? Where is it?
Yeah, and you're always going to look at the, you're going to look at the mandibular molar and take it from that way, because it'll be backwards if you look up top. So if the mandibular molar is forward a little bit, it's mesial step, because it's going mesial, and if it's backwards, it's going backwards, which would mean it would be distal.
Okay, so like in a class 3 malocclusion, it would be mesial, right?
Yeah. Mm-hmm.
Yes.
Exactly.
Yeah.
Okay, I got it.
Yeah. So yeah, no problem. No problem.
Yes, I have a question.
Sure.
On the occlusion part and in Patterson, there is something that says division.
Yeah. So back where Miss Valerie discussed about the class 2 occlusion, there are 2 divisions of those, as she said.
Okay.
That's where you're going to put that division. She's floating back. Hold on one second.
I'm going to flow back. Yes, there's you have to remember that class 2 has division 1 and division 2. So I'm just going to leave this up. This is a nice comparison of the 2. If that helps. So really it has to do with the overjet and the overbite. So division 1 in class 2, you've got a real flare of the central incisor. So it's kind of making the lip jet out a little bit. And in division 2, those central incisors are kind of tipped back and in. They're not protruding out. So the lip on a profile view looks kind of normal.
Okay. And also next to it is maximum opening unassisted, that's how you say it?
Mm-hmm.
What does that mean?
So maximum opening unassisted, is that what you're asking? That's how that's how far open that a patient
Wide.
can open their mouth,
Their mouth.
wide. So if you have someone who has like really bad TMD, which is temporomandibular joint disorder, they might only be able to open their mouth like an inch maybe. So that's what that would be. And assisted would mean you actually going in there and manipulating the joint. Really.
Yeah. In a lot of cases like that, I have referred patients for physical therapy to work on that. They have small, limited opening. It makes it impossible to clean their teeth. And sometimes a lot of that comes with pain. They can't physically open. So sending them for physical therapy and doing exercises to kind of loosen that joint helps to get that more to a maximum opening space.
Okay. Thank you.
How would you measure that opening
Hello?
with
Hi, it's me. I'm sorry. I was in the car getting out, and you guys have some really great questions. Valerie and Ashley, thank you for answering that. I just wanted to say that because I was like coming out the car and fumbling with my phone. So thank you. I was like, I can't. Okay. So I just wanted to say that. Thank you.
Thank you. Thank you for joining us.
Yes. Does anyone else have any questions before we move on to the case study section?
For the wear facet, is all in the posterior or it can be also in the front?
So for me, I feel the wear facets are more on the posterior teeth. They look like potholes. That's the best way for me to describe them. They are round, perfect little potholes, if you will, where the upper and lower cusps are constantly in contact. It creates this crater kind of look. And you see it in the posterior. A lot of times they're really sensitive because the enamel has worn so much in those areas that the dentin is showing through. And we all know that dentin is very sensitive. In the interior, you're going to see more of a flat, jagged edge. Again, you'll see the dentin too in some instances. In some very severe cases, you'll even view the pulp. Then you know you're kind of in trouble when you see that. But wear facets are typically a posterior.
Okay, thank you.
You're welcome. Are there any more questions with class 1, class 2, or class 3?
No, thank you.
Okay, so we're just going to do a couple of case studies just to kind of test some of your knowledge and just so you can see some real patients and their mouths. And we're going to go towards that. Give me a second.
So Val, it's not letting me share, so I'm going to have you man it and I'll talk.
Yeah, I'm going to stop sharing.
No, I don't think I can because the host disabled my sharing rights.
Okay, let me try to.
So just go ahead and open it up and I'll talk over it. It's
okay. Okay, so let's go back to this. All right, sorry about that. All right, so our first case study is here. And, okay. Oh, nope, that's not what I wanted to do. Sorry about that.
okay.
I have to go through them quickly. Okay, so this is our first case study, and Ashley's going to review the case studies, and we've got some questions with a couple of them.
All right, so this we kind of outlined like you would probably see on a case study question. So I just wanted to kind of show an overview and talk about it before we go ahead and go to the pictures. We have a couple sets of pictures. So looking at this case study, medical history wise, demographic wise, looking at an 11-year-old female. So we have a pediatric patient. History of trauma on E and F at the age of 2. Now, I have a question for everyone. What type of occlusion class is at probably the highest risk of trauma for the anterior teeth, the maxillary anterior teeth? Does anyone know? Do I have a guess?
Edge to edge.
That's a good one too. So that would be more if they get hit from the chin up. That's a good one. But what's another one that's like super, very prominent as well?
Class 2, Division 1.
Yes. Who said that? Who was that?
Yeah, who said that?
Anna.
Anna, good job, girl. That is correct.
That is
So
correct.
when you have a patient who has the severe class 2 Division 1 and they are flared, fun fact, I don't know if anyone knows this, your nose is supposed to stick out more than your teeth because just in case you fall, you'd break your nose instead of breaking your teeth.
Right.
Okay. So if you're a class 2 Division 1, usually you flare out so far, and I'm sure you've seen the kids where they flare out so much that they're at risk of really damaging their teeth if they fall. So they're one of the cases where you will send to the orthodontist, but you will also stress sports guards for their teeth, because if they are playing a contact sport, they are at like severe danger zone. So keep that in mind. But that's not the case here. We do have that this patient had a history of sucking fingers as a baby, but is no longer a habit. And we briefly touched upon it, but what is one of the characteristics of a patient who has a habit of like a pacifier, a thumb, or sucking on their fingers, and how their bite will be?
Open bite.
An open bite. Good job. Perfect. If the patient, usually if they stop it by 3, it can self-correct itself. So that's a great one. So no longer that. Small incisal chip on 8, that's fine. No history of decay. And the patient is unhappy with the spaces in the upper manterior, and the mother would like a ortho referral. So we're going to go to the next slide. And we're going to see that this is Mrs. Valerie's daughter.
This is my daughter.
So let's take a look at Brooke's teeth. Miss Valerie, if you can go ahead and move forward one more slide.
Yep. Not sorry. Oh, they were backwards, the slides.
There you go.
All right, we'll go back. That's okay.
No, that's perfect. So we're going to go ahead and take a closer look at this one, okay? So let's start right down in the middle, right under Brooke's name. You're going to take a look at where her midlines are. So her midlines are lower to the left, probably by like 2 millimeters or so. So that's something you're going to go ahead and you're going to consider, right? We're looking at the incisal wear on this the upper right of the screen. You can kind of see how we have some chipping on the anteriors as well. And then we're going to go ahead and we're going to start taking a look at the occlusion. And we're going to look at, you can look at the canine relationship, and you're going to also look at the molar relationship. And also it's helpful as well to take a look at the side profile of you, because you're going to see a better look at where the overjet and the overbite will be too. So we're going to take a look at this, and I will give you a hint. She has 2 different occlusion classes.
Yes.
That's my hint. That's my hint to you. And my next question is going to be, what is her occlusion class on the right side? And this is the patient's right, so it's going to be our left, just so you know. So what is her occlusal class on the right side?
Class 2.
Yes, good job,
Yes,
Anna. She is a class 2.
She
Now,
is.
next question is going to be, which division of class 2 is she? Now, she's not a severe of this, but it still does count. So which division would she be?
Division 1.
Yes, Division 1. Good job. Perfect. Now we're going to go ahead and we're going to switch to the patient's left. So what molar classification is she on the left?
Class 1.
Yes.
That's right.
Excellent job. So
Yeah.
she's a class 1. Now you're also going to notice if you take a look at the patient's right side, what can you see with the relationship of the maxillary arch and the mandibular arch? What are those teeth doing?
They're in crossbite.
They're in crossbite.
They
Good
are
job.
in
So
crossbite.
she has a right posterior crossbite.
Yep.
She has the flared anterior teeth. And now I would like everyone to take a look at the side profile view. And we're going to estimate because we don't have our probe, so we don't know for sure, but you kind of can guess. What do you think her overjet looks like? Now, another way to remember how to find overjet is you're going to think of a plane. A plane flies that way, right? Like a jet plane. So you're going to think about it going horizontal, okay? So looking at that, how many millimeters do you think that would be? Just like an estimate.
3.
Yes, I would say that would be a 3. That's what I guessed too. I was going to say a 3.
Probably.
And then, yes, and now an overbite. Now, also, I just want to say a common misconception is people are like, oh, I have an overbite. You're supposed to have a little bit of an overbite because if not, you're edge to edge, and that's bad news. So what is her overbite? And again, that's going to be how much the top tooth covers the bottom tooth. Just a guess, how many millimeters do you think?
3.
Yeah, it's like a 3 or 4, I would say.
Yeah.
So this patient is going to go ahead and see the orthodontist. And there's a couple of treatment options the orthodontist could do. Now, another thing to touch upon is it depends on when the person sees the orthodontist. And I'm going to go over that with the next slide. The American Academy of Pediatric Dentistry recommends that patients see the orthodontist at the age of 7 for this reason. It's mostly for bite and occlusal reasons. And that's because you have to adjust some bite issues, especially class 3 when they're younger, and I'll explain why in the next slide. But looking at this, can anyone guess what kind of orthodontic treatment that Miss Brooke would probably go into?
I don't know if a palate expander or just regular braces.
Yeah, so that was a really very good.
That was good.
So, yeah, palate expanders are great with helping with crossbite. What happens is it gently right there you have the arch on the maxillary the maxilla. You have the suture line. It gently kind of moves it out, and that'll cause the molars to be able to shift outward. So it could be a combination of an expander and traditional braces. It could be a combination of an expander and Invisalign. And that is just up to the discretion of the orthodontist and also the compliance of the patient, because there's so many other attributes you have to take into consideration. Good job. That was awesome.
really good.
Yeah, I'm super happy.
I will, if I can interrupt you for a second, we are not doing a palate expander, and we opted to try elastics on one side for a few months because the elastics can also have the same effect with being a little bit more conservative. If you look at her upper arch, she's kind of gotten that nice U shape, but we just kind of have to kick out that molar right there. And so we're gonna go with an elastic on that side for now. So we'll see what happens. But her treatment looks like it's gonna run about 24 months. And she's getting them on next Wednesday and not happy. So,
all right.
It
next
is what
slide.
it is. All right, next slide.
So we answered these. All right.
Okay.
Here is slide letter B. So taking a look at this individual, I was able to find both of the side profile views and also the direct vision of this one. So taking a look at this, even just from the straight on head on view, what occlusion class is this person?
Class 3.
Class 3, good job. And the reason why it's a class 3 is because
the mandible is protruded to the front.
Exactly.
Yep.
We have the stereotypical kind of bulldog bite. And in this case, we have it on the left and the right side. Now, what is the occlusion condition that is present on this patient? Can anyone see that one?
It's an underbite?
Underbite.
Yes, we have an underbite, and we also have a bilateral crossbite in the posterior, and we also have a crossbite in the anterior. So this is like a picture perfect class 3 bite. This is what you're going to find here. This patient, I'm going to do more before and afters when we talk about orthodontic treatment in one of our upcoming study sessions. But I will say this patient further after, they did need to have surgery. And that is more of a jaw type surgery, but we'll talk about that another time. Now, finding the overjet for this patient is still possible, but it's going to be different. Can anyone guess how that's going to be different?
You would have to measure it like backwards?
Yes. Now, what happens if you measure something backwards? What does it then become?
Negative.
Negative. Good job. It becomes negative. So in this case, looking at this person, again, we're just estimating because we don't have a probe. The overjet looks like it's probably 2 to 3 millimeters or so, I'd say. And then the overbite is going to be what?
-2, no, -3 maybe.
So in the overbite, it doesn't really change whether it's positive or negative. You're just kind of looking at the percentage that the tooth covers each other, but you are correct. It's like 2 to 3 millimeters. So that is fantastic. Great job, guys. Okay,
Yeah,
next slide,
really
please.
Next one.
All righty.
Oh.
Now we have this one. This is a fantastic after. So I will touch upon this one again in one of the next ones. She went through a lot to get where she is now, and her teeth, you will not believe the after picture of this. But all right, so we have this patient. She has an over retained root tip, if that's what that mark is. On her patient's right side. Anyway, if you can go ahead and take a look at her, what occlusion class is she?
The class 3.
Class 3, that is correct. So you have the typical underbite, you have the bulldog look. Now, she also has something else as well, a condition-wise. What condition does she have?
Open bite on the right side?
She does. She actually has a bilateral open bite. And because of that, she, what can't she do?
Chew?
Yeah, she can't close her mouth. She can't chew. She can't close her mouth. So when you can't chew and whenever you bite down and you're not occluding in any shape or form functionally, what is that called? Does anyone know what that's called?
No, I do not know that.
Yeah. So in this case, this is a case of traumatic occlusion. So if you take a look at her teeth, she literally only has contact on her second molars. And when she had this fixed, she went to me and she was like, I can finally chew my food. And it's something that you take for granted sometimes. How these people, really their functionality is just completely hard on them and they have to adapt and it's difficult. So that was great job. All right, so we have one more.
It's interesting.
All righty. Okay, so we have one more. Now, she does have an oral piercing. Can anyone tell me what are some of the risks involved with having an oral piercing, especially one of having a ring like this?
That will be more like, it will cause him like gingival recession in that area.
Totally can. So right there, actually the piercing is on the frenum. But because of the way that that is and the size of the ring as well, what else can happen?
Erosion.
It wouldn't really, so erosion is usually caused by more of a chemical reaction, I guess we'll call it, like acid, something like that. But this is perfect for fractures. This is a recipe for having a fracture. So especially with the balls on the end of it. So moving on from the oral piercing and taking a look at this patient, what classification of occlusion do we have? And I will give you another hint, it's two different ones. What is on, let's do the patient's right side.
Class 2.
Anyone else?
I think it's class 1.
Nope.
Class 3.
Yes, it's class 3. So this is a class 3. This is a class 3 occlusion.
Great.
And you can tell that from the relation of the mandibular first molar and the maxillary first molar. You can see it's almost at a complete diagonal from where they would be. So that's the right side. And then moving on to the left side, does anyone have a guess on what that would be?
Class 2.
Okay, anyone else? Any good guesses?
Class 1.
Yes, perfect. So this is a class 1. This is a class 1. And in this case, we have a 3 on one side and a 1 on the other. And this is a really good example because looking at this patient straight on, she doesn't have that bulldog underbite look. So this is a really good example of that. This can fake you out. So again, the skeletal class of this patient might not be a class 3 skeletal class just because they have class 3 on one side. So does that kind of bring that together? Exactly. So what else do you notice about this patient and their occlusion?
Crossbite on the left side.
Good job. So we do have some cross bites. We have tooth numbers 5 and 6, the way that they occlude with 27 and 28, and also for 12 and 13 and 20, 21 and 22 actually. So we do have that going on. Excellent job, everyone. So what would be, yes, what would be the overjet, do you think, in this case, estimated?
1 millimeter.
Yeah, 1, maybe even like a 0.5, to be honest. It's pretty close. So if you have a patient who has a 0 overjet and a 0 overbite, what would they have?
Edge to edge.
Edge to edge bite. There you go. Perfect. Perfection. But in this case, what is the overbite in this one? Just a guess because we can't really see.
Maybe 3, 2 to 3.
Yeah, I would say 3. I would say about a 3 millimeter. Good job, perfect. So in this case, because this patient has a localized, she has a bilateral crossbite, but she's not really pronouncing then that typical class 3 look. This patient was able to go ahead and correct this bite with Invisalign treatment. Nice. Again, you're going to use a combination of rubber bands for tension and a bunch of things. So that was pretty much just an overview of occlusion, what to look for. Again, like I said, in one of our upcoming videos, I'm going to really go over orthodontic treatment because as a hygienist, you're going to be the front runner for that, to catch it, to tell them when that they should go, and kind of quarterback that one because that's really important and a lot of education is needed. Even education in the occlusion class is needed too, because you can have a parent who says, my kid is 7, why are you sending me to the orthodontist? They're just baby teeth. But that's going to go ahead. That is pretty much the blueprint for the rest of their occlusion. So it's really important to take care of that. Does anyone else have any questions for us in regards to occlusion, malpositioning, anything like that?
Treatment planning,
Yeah.
signs.
I have a question.
Guess not.
Yes, go ahead, Maya. I'm sorry, honey.
For the edge to edge bite, how would they fix it?
For an edge-to-edge bite, how do they fix it? All right, so that's a really good question. So it depends why that they have an edge-to-edge bite. Usually if they have an edge-to-edge bite, it's because they're almost a full class 3 occlusion. So it's going to go ahead and it's going to probably be a little bit of expansion and a little bit of orthodontics to go ahead and just pull the teeth back a little bit. Edge-to-edge bite can also happen with a class 2 occlusion as well, if it's like right on the cusp, and then that would be addressed in how they would fix a class 2 occlusion bite. Class 2, really quickly, class 2 occlusion orthodontics. If anyone's ever heard of Herbst appliance before, what you're doing is you're putting pressure in the back and shifting everything backwards to kind of compress in. But we'll touch upon that when we get to the orthodontic stage.
Right.
That was an excellent question, though. That was really good.
Mm-hmm.
Thank you.
Is there anything else? Anything in the chat? I'm just going to check.
No, I have it open.
Okay.
All right, everyone. So we're going to call it here. Next week, we're going to be doing a review session for your first examination, same time, and we will take it from there. If you have any other questions that you think of, please feel free to message Mrs. Valerie or myself, and we'll get back to you.
I just wanted to let you guys know that I'm going to upload this video, and I also have a cheat sheet for you. Just a quick reference guide of all of the classifications that you can go right to and use as a nice resource when you're trying to differentiate between the classes. So I'm going to upload that for you also.
Thank you.
So, thank you. Thank you for joining us today.
Thank you.
Awesome job, everyone. Thank you so much, Miss Valerie and Miss Ashley. That was awesome. Thank
Hey,
you.
no problem. Bye, everyone. Have a good night.
Have a good night.
Bye. Bye.
Bye.